We're still at Wake Forest University here in North Carolina, where the Bowman Gray Medical Center is located. And we are continuing in our exploration of the health crisis with emphasis today on costs. Do we need federal intervention in order to keep costs reasonable? Stay tuned.
This program is a Warren Steibel production in association with South Carolina ETV. Funding for Firing Line is made possible by a major grant from the John M. Olin Foundation, Incorporated. Additional support is provided by the Annenberg Foundation, the Laurel Foundation, and the Friends of Firing Line.
We're here at the Bowman Gray School of Medicine at Wake Forest University to ask whether medical costs can be controlled. And once more, we let one of our guests state the agenda. We have here Dr. Ward Kurad, who was educated at Duke and at the University of Maryland, and served as a general surgeon in the Air Force before turning to the practice of urology. Recently, he quit medicine. He was, to quote him directly, burned out on the paperwork mill and the hassles with insurance and Medicare. He is president of something called Healthcare Planning Associates, about which we will, of course, be hearing. Dr. Richard Janeway is the dean of Bowman Gray Medical Center, familiar to those in the audience who were with us for the first program. Dr. Charles Sanders was at one point the general director of Massachusetts General Hospital and a professor of medicine at Harvard Medical School. He is the past chairman of the New York Academy of Sciences and is now the chairman and chief executive officer of Glaxo, Inc., a pharmaceutical company. And he is therefore ex officio qualified to talk about rising medical costs. I turn the chair over to Dr. Sanders.
Well, thank you very much. The answer to your question, are medical costs controllable? And is clearly yes. The question, of course, is how. We're now debating the issue of healthcare reform here in the United States. The President and the First Lady have done us a great service, I think, in putting the issue on the table. But as usual, in the solution, the devil is in the details. I don't think any of us can really deny or oppose the universal access, the principle to health insurance. But I think we also have to remember as we approach this question that we have the best medical care system in the world. We have the highest quality, and it's the most innovative. And people come here from all over the world to take advantage of this great medical system. The difficulty that we have, of course, is that it's not available to everyone. And although we have had a healthcare crisis described to us, which is, of course, a very emotive term, I would argue that we have a crisis in part in terms of access to health care for a certain segment of our population.
But wait a minute, but let's concentrate on the direct question, which has to do with cost. Let's assume that I think you're correct, we have the best medical system, medicine in the world. 5 years from now, can we have the best medical medicine in the world making the same economic sacrifices? Or is there something built in to the vector of that line that says it's going to be more expensive? We're charging now 14% of the GNP. It'll be 16% 5 years from now. What's going to keep that from happening?
Well, what's already happening, and that is the market is really working. Since 1986, managed care has become more and more an element in our medical care. 23% of care in the 1986 period was given by managed care, capitation, cost containment type of activities. That had risen to 47% in 1990. It's going to go to 75% in 1995.
Now describe the economic impact of that, if you will.
Well, what that does is what we're already seeing. In the last year, medical care costs have risen only 5%, which is the lowest in the past 20 years. In my business, in pharmaceuticals, we have risen at the rate of the CPI, so that the market forces are working, and they can work. And medical care, I think, will come under control. And we're not going to go to 16 or 18 or 20% over the next 10 years.
Does anybody disagree with that?
Well, I think that those costs which are controllable will be controlled. there are some things that just cannot be controlled. One is the aging of the society, and that is going to increase the number, and the country continues to grow, so that you're going to have more people within the system, and the older people are larger consumers of medical resources than are people, say, from the age of 19 to 64. So
are the implications I accepted? Let's say you probably have the exact. Let's say 5% of the population was over 80 10 years ago, and is now 7%. That means an enormous increase in medical expenses, doesn't it?
Yes. The medical expenses for someone at the age of 85 are about 7 to 8 times the per capita cost of people in the age group from 19 to 64.
Okay. Now, is there anything in the market system that you're talking about that's going to diminish the cost of care for the elderly?
Yes. And the fact is that if we're able to sustain the innovative characteristics of this particular healthcare system, building new effective technologies, pharmaceuticals, for example, supporting the development of breakthrough drugs that will take care of osteoporosis or benign prostatic hypertrophy, Alzheimer's, and so forth, there's tremendous opportunity here if we sustain innovation. If we don't, then I think that the cost of medical care is going to go up much more rapidly than it would otherwise.
Now, is this the paperwork that drove you out of the shop something that is, in your judgment, clearly inhibiting this kind of innovation?
To some extent.
Of energy?
To some extent. I think the major driving force in this cost control that Dr. Sanders has been talking about has been the business community that over the last 10 years has said enough is enough. We have to control this, and started to form partnerships with the providers. And in doing so, there's a lot of give and take. And one of the things that is being put on the table is, let's form these partnerships, and part of that partnership will be to eliminate some of this paperwork business. Let's get a direct kind of arrangement. And the big businesses have been able to do that. They've gone in and worked out arrangements with networks, physicians, hospitals, so on, for direct services. And this has been very effective.
Without any sacrifice in quality?
Without any sacrifice in quality. In fact, most of the larger companies have built-in measures of that quality, and it's been very effective.
If you talk to the employees, they're really pretty satisfied with the quality of care that they get. They have incentives for preventive care, and they have incentives for utilizing the system properly so that they don't overutilize. And I would argue that one of the biggest costs in our system right now is the inefficiency with which we use it. We overutilize it.
Charles, when you say that one of the things that has changed in the insurance provided, health insurance provided by companies, is that there's been more emphasis on co-payment and deductible, and putting a little bit of the pain back into the purse or the left hip pocket. It makes a much more sensible consumer.
A much more informed choice.
Yeah.
I've been stressing for the 5-6 years in which I've touched on the subject, an insight given to me by a doctor at Fort Worth, which is that no reform that doesn't cause economic husbandry to inure to the benefit of the person who exercises it is going to work. Unless the money flows back to you that you didn't profligately spend, you're going to go ahead and spend it. Now, that force can't come into the mechanism, the market mechanism, can it, as long as business is paying medical costs and deducting them?
Well, the way it's currently set up, no, it can't. But the co-payment principle does get a little bit toward that particular point. There are some proposals, as you know, in the Congress that would set up medical savings account in which people would use those and they'd have choice, and that would, I think, would get to that particular point, and that's attractive from that. The question is whether or not that gets us to universal access, and the opponents of that approach would say, no, it doesn't.
Well, but isn't that an entirely different discipline?
It is.
I wonder if I could be a little provocative there. I think,
No.
we...
Well, certainly not on this show.
But we hear all the time about 37 million uninsured Americans. And to an extent that is true, but it is not the same 37 million people every day. Now, at some given day during a year, that's true. But the average, the person in that, on average, is 40% of them are no more than 4 months without health care, And 70% of the people in that group get coverage within 9 months.
They're all writing letters to Hillary.
Well, and she's answering them too.
Yeah, no, that's right. 37 is kind of a neat demagogic figure. It's like the unemployment figure. Part of that unemployment is people who quit a job because they want a better job, but they nevertheless register as unemployed. Right. And the same kind of hanky-panky is played with the 37 uninsured, isn't it? To a certain extent. To the extent that you point out.
30, yeah, right.
Yeah. But still, what is it that what's magic about the percentage that we would tolerate that the American people should spend for medical care?
There's nothing magic. We choose to spend the 14% that we're spending right now. That's the American way. Yeah. If we choose to spend 14% and no more from now on out, I guarantee you that we will face a time when we will have rationing and queuing up for procedures.
Unless you have commensurate economies.
Unless you have commensurate economies. But if the government is in charge, and there is not that driving force of where you're the economic husband of your economics of your health savings account, then I would argue that we'll just continue to utilize services up to the maximum, and the price will inexorably rise.
Well, is it not true that socialized medicine in Canada, in fact, has not succeeded in reducing the rise in medical costs as a percentage of Canadian income?
Yes.
I.e., it's not a magic nostrum, is it?
Oh, and this is really the reason that Dr. Janeway pointed out. There are some elements of the cost of medical care that you really can't control, like the aging population, like the use of some technologies, and so on. And this is one of the things they've found out, that even though they can budget and limit expenditures, that does not cut down on some of the demographics that are forcing them to spend more on medical care.
And I think we shouldn't forget that many of the things that just seem to go on at a high level in our society, the crime and violence, the drug problem. I heard a talking head this morning out at 6 o'clock on CNBC that said that $674 billion a year in total cost of crime and violence in this country. And somebody last week had talked about the cost.
That's got to be wrong. Not $674 billion.
$674 billion. That's what he said.
Well, that would be more than 50% of the of the federal budget. Did you say that?
Yeah, well, maybe that's how it affects the GDP. I don't know. But the thing is, crime and violence and drug utilization, all that stuff gets pushed on at some level where the healthcare system has to deal with these people. And until that's controlled, that's an uncontrollable cost.
Yeah, let me just point out one thing about the Canadian system, and that is that the Canadians are very heavy utilizers of the American system. That, you know, they come across the border with regularity to seek the high technology that's not available to them in Canada. So that one of the best things about the Canadian system is the proximity to the U.S.
One of them said they're scared to death that we change. And no place to go.
On Dr. Janeway's point, has anybody done the mathematics on the extent to which crime adds to the cost of medicine annually? Has that been?
It may very well have been done, Bill, but I don't know the exact figure, but it's got to be a lot. I mean, we had 2 people in our emergency room. One stabbed, the other one shot, and you talk about the Long Island Railroad. I heard there's one person whose bill is going to run $250,000 for that shooting episode on the Long Island Railroad. Big, very big.
The other aspect, you know, that's frequently laid at the problems laid at the foot of the healthcare system is infant mortality. And that would seem to be a fairly straightforward obligation of the healthcare system, but actually it's education. It's economics and people, teenagers becoming pregnant and having enough intelligence to go and seek out advice about how to take care of themselves. Japan had one of the highest infant mortality rates in the world up until the 1930s when they got into a very simple education program. Now they have one of the lowest. I would argue that's not health care. That's just plain simple education.
Yeah, but we really must concentrate on the economics of health care because that's a question that people who have no professional involvement in the argument find only Mr. Clinton seems to be answering them, i.e. if, as was the case during the past 8 or 10 years, the cost of medicine goes up 7%, which is half again as much as what can they project for their children 20, 30 years from now. Now, can you say, Dr. Sanders, that even though we can't protect them against factors that are unchangeable, like increased health care for the aged and so on and so forth, that the market forces are now unleashed, which will bring them relief?
Well, I don't think there's any doubt about it. I realize the critics would say this is just a one-time thing, that it is not going to stay. It's just because the President and the First Lady are very concerned about the issue and everybody's hunkering down. I would argue that these changes in terms of the market really began in the late 1980s and are persisting. And it's simply because of the fact that economically, large companies, and even small businesses, of course, just can't afford the health care insurance cost as they continue to rise in double digits. Something has got to be done. We have to make affordable health insurance available. And the rise in managed care, the HMO, PPO, IPA approach, the organized care team approach to medicine is really the order of the day. And by the way, that is the group that is going to force more and more primary specialization into the system. And there will not be a job for the high-priced specialists. There just will not be a position. They will not be able to get hospitals, hospital staffs. They won't have operating room privileges.
Why?
Matter of fact,
Simply because of the fact that hospitals will not, if they're an HMO hospital, then they were only going to hire so many cardiac surgeons, and that's it.
If you're an unaffiliated suburban subspecialist, 3 to 5 years from now, you're redundant.
It's going to be very tough.
Why are you redundant if there are people who are suffering from something that you are equipped to minister to?
Because I think that you're going to have to be part of a plan or a series of plans in order to participate in the system.
There's very poor utilization in the system now, and this is what the whole managed care concept is about. You know, most of us grew up with managed care. That was the neighborhood physician who told you when you went to work and told you when you went to the hospital and told you when you went to see a specialist and who that would be. And that's probably the best form of managed care. But that's what we're going back to, is somebody is saying, no, you don't need to go to a high utilization, high cost area. You can stay here and we can treat you. And that's the reason you don't go to a cardiologist if you have chest pain, or an orthopedist if you have back pain. You see the primary care people first, and that's the reason there's less need for these people.
Well, Dr. Kurad, let me ask you this. In the direction in which we've moved in the past few years since Medicare, there has been this enormous increase in paperwork. I saw the figure that we spend on paperwork as much as the Canadians spend on medicine, about $130 billion. Now, my question is this: why didn't the private enterprise system come up with a means of coping with that paperwork? With computer technology and what we now know, why is it such a heavy burden?
I'm not sure I can answer that. I think most physicians have been very reluctant to change. You know, there's been a great deal of reluctance to even go to electronic filing for claims, and there have been overtures to develop information highways between the hospitals and the physicians' offices and so on. All of these things would help to eliminate some of that paperwork.
And therefore diminish costs.
Yes. Yes.
And have you any idea why it has not been just that physicians are
I think there has not been a great deal of incentive. I don't know. What is the reason?
Well, no, wait a minute. I wouldn't put it all on physicians that they didn't want to do electronic billing. Well, at least we have a very large practice, and we have essentially pushed other organizations to create electronic billing. We deal with something like 1,300 insurance companies, and our people tell me that each one of them has a different form.
And I think that's where we can
introduce
some real reforms there.
Such as what?
Well, I mean, you'd have a uniform billing.
Yeah.
I mean, a form which is a one size fits all. There's nothing wrong with that. That's not going to harm the system and reduce the cost.
Whose turn is it to take the initiative in a reform of that nature? It doesn't have to come from the White House, does it?
No, it doesn't. But it has to come from some centralized agency, I think. I'm afraid this is a place where the government does take a role.
In terms of the simplification of forms, that people could gain sort of uniform acceptance of the forms, but I would hope they need not go too much further than that.
Well, the American Medical Association, why, for instance, doesn't it take the initiative in a reform of this nature?
Well, it has pushed, I think, very hard, the AMA has pushed very hard on that.
Some businesses have done this, and I mean, the large businesses have used this as a part of their mechanism for controlling cost. And they're saying, if you do business with us, you use this form. And it's been effective. But I agree. I don't know that that's something that can be done outside of federal intervention. I'm just not sure that
I think it's probably important to realize that there's some very good things about this healthcare reform approach. First of all is the goal of universal access. The second is trying to put in some insurance reform, such as we're talking about. The third thing is getting the people who do not have insurance all year long, some 5 to 10 million, not the 35 to 40 million we're talking about, taken care of, so that they really don't have to worry about whether or not they have access to health care insurance. Making sure that there's portability of insurance between jobs, so if you don't have so-called job lock, that you're afraid to leave your job because you can lose your health insurance. That can be taken care of, and you can take care of the upper end, the catastrophic illnesses, with fairly simple insurance reforms at some cost, but not at the tremendous cost which is projected for the whole overall bill.
I would agree with Dr. Sanders that I think that the two things that are really doable and most important are the portability, or the interim to prevent job lock, and the second is to have some kind of mechanism for reasonable cost health insurance when a person has a pre-existing condition. And those two things, I think, are relatively easily fixed at not a huge amount of cost to the American public.
You don't have to reinvent medicine to do that.
That's right.
You don't have to reform the whole system to do that. You just tweak it.
You have to what?
You don't have to reform the whole system to do it. You have to tweak it.
Well, if one were obliged, say at age 18, to take a catastrophic health insurance, and having taken it, the company that sold it to you were obliged to maintain you at that current price level, would that be a basic reform of a kind that you would welcome?
Sure. Yes. Yes, I think I think if you were assured that you would be covered if you had an illness of, costing you much more.
More than 5% of your annual income, something like that.
Something like that.
Yeah.
And I think that would go a long way toward addressing the concerns that the people have, and certainly getting a lot of the emotion out of this argument.
Well, the 20-somethings who are counted in that 37 million, it's about 17% of the total, they in effect have made a decision to self-insure. Yeah. Because, from 20 to 35, you really feel like you're kind of immortal. Mm-hmm. And in fact, you are. I mean, they spend an average of $711 a year, and that's only 40%.
But under the Sanders-Buckley plan, they would have to insure for catastrophic.
Absolutely. Absolutely. I think that they can take that responsibility. Personal responsibility is a wonderful thing, except when we have to pay for their bills later on, which is what is happening now.
Yeah.
That's the famous cost shift. If the uninsured goes into a hospital and they don't have any money at all, then the insured are the ones that pay for them, and that's you and me.
Well, have you, has the medical community, sensitive to this issue, come up with a figure that they consider to be reasonable as a deductible before catastrophe sets in? What is the working figure at which, let's say you're earning $30,000 a year?
I think $2,000 would probably be the place.
About something just under 10% of your income. And the catastrophic bill that almost passed a couple of years ago, did that set a figure? Do you remember, Dr. Kurad?
I do not know.
It did set a figure, and I don't hold me to it, but I think it was right at 2,000 or 2,500.
And that would be irrespective of a person's income?
Yes.
And now, if that were in place and were irrevocable, that would settle a considerable part of Mr. Clinton's complaint against the existing system, would it not?
That's exactly right. And put in a uniform billing process, and you've got it made.
But it's not splashy enough.
No, it's not politically appealing.
You wonder how much hassling of a system or reform. And I agree with Dr. Sanders. I think that the surfacing the public debate is extraordinarily useful about healthcare reform. It's a little bit like the Hawthorne effect. I mean, some things happen just because of the discussion. But I believe we don't have a crisis. You know, the 75% of people who get interviewed say they think it's a crisis, but you turn around and ask them, and 80% of them say that they're perfectly happy with the kind of medical care they have and their own insurance. So,
well, you know, the trouble is a crisis is really an individual crisis. I mean, Hamlet had a crisis,
Yes.
but Denmark didn't. and you know, the guy who wrote Hillary Clinton, he had a crisis.
absolutely.
Language is so sloppily used that crisis now becomes sort of a useful word to depict, to transform a particular into a general situation. And as I understand Dr. Sanders, because we've talked about this before, the point is to isolate the particular weaknesses and not simply dismiss the whole as a crisis, as Senator Moynihan seeks to do.
That's right.
Is there, we only have half a minute left, is there a state that has experimented with reforms having to do with economies that especially strikes you as successful? Hawaii, Minnesota, Washington?
Well, I think it depends on who you talk to. Hawaii is appealing because it appears to have contained its health care costs. It's a very special population, however. I think Florida is initiating some programs which look interesting. It just started this year. Oregon, of course, has started a program which quotes ration care, but it's really a very mild form of rationing. I really think that if we let the states do it and try it on their own, they will come up with a lot better solutions than just having an overall arching federal system.
Thank you, Dr. Sanders, Dr. Kurad, Dr. Janeway, ladies and gentlemen of Wake Forest University Bowman Gray Medical School. Thank you. One thing we forgot to get into with the lawyers.
This program was a Warren Steibel production in association with South Carolina ETV. Funding for Firing Line was made possible by a major grant from the John M. Olin Foundation, Incorporated. Additional support was provided by the Annenberg Foundation, the Laurel Foundation, and the Friends of Firing Line. For information about a video cassette of this program, write to Firing Line, 2700 Cypress Street, Columbia, South Carolina, 29205, or call 803-799-3449. That's Firing Line, 2700 Cypress Street, Columbia, South Carolina, 29205, or call 803-799-3449.